will serve as the chair for this session. And so we are fortunate to have a distinguished group of speakers, audience, and who will share their experience and perspectives on different approaches to the mitral valve intervention, including open heart surgery and transcatheter repair strategy. So each speaker will have 30 minutes, and we will allow questions and at the end of each talk. Before we start, I have some announcement from the ACVS. Please visit exhibit hall today and tomorrow for exhibit and refreshment breaks and lunch. And be sure to bring your lunch voucher with you. And don't forget to kick off your evening friends and colleagues at tonight's happy hour at 6 p.m. in ballroom 6CE. And search ACVS events in your app store to download the Surgery Summit mobile app for the most current schedule and conference updates. And you can customize your schedule, track CD credit, and access proceedings note through the app. And finally, mark your calendar for next year ACVS Surgery Summit at Charlotte. It's going to be October 7th through 10th. We hope to see you next year. And let me begin with the first presentation. So my presentation is introduction to mitral valve repair, open heart mitral valve repair, and how to set up a program in the US. This is Katsuhiro Matsuura. I'm doing clinical assistant professor in the University of Florida. I will give a brief background later. And I have no interest regarding this presentation. So this is the slide of my self-introduction, and I got a vet license. I was born and raised in Japan, and I got a vet license in Japan, and I had a training for perfusion for open heart mitral valve repair and surgery in Japan from 2014 through 2019. And my very first experience doing open heart mitral valve repair in Japan was 2019. Since then, I did like 55 cases until I published the first paper about the outcome. And you can find my statistics in this paper. And after this period, I was invited to start the open heart surgery program in the University of Florida. And after that, we did surgery with so many great staff working in the US hospital, UF hospital. And last year, we started surgery fellow program. This is really associated with my goal to expand this surgery to as much as possible in the US, because dogs are dying of this disease, mitral valve disease, every day. But it's difficult to have a new surgeon in a short period of time. But now I will explain some about the federal program later. And then this year we also started perfusion federal programs specific to veterinary perfusion. So this is a short slide for my background. So here, I'd like to explain why surgical repair for mitral valve disease matters. I can imagine most of you already know having some knowledge about this, but let me do this first. And this is the easy example of severe mitral valve disease. And you can see the chambers. This is the left atrium and left ventricle. And you can see the mitral valve in between. This is the anterior mitral valve leaflet, and this is the posterior leaflet. And when you put the color on this, you can see the back probe showing the mosaic color, red, yellow, green, blue here. This is the regurgitation. And with this severity, the patient, this patient was stage D, Chihuahua, and we have to expect the median survival with medical therapy. Even with extensive medical therapy, the median survival time will be about 200 to 300 days. And this dog had a surgery, and it seems, I think it's just 1 year after surgery. The dog had successfully remodeled, and then you will see the regurg is much better, almost close to 0, and the chamber size is getting closer to normal. In that case, after open heart surgery, in my statistics outcome from Japanese, my experience in Japan, we got this good survivor curve. It's pretty rare to have a cardiac death after long-term after surgery, and it will not reach to the median survival. So that's why surgical repair for the mitral valve disease really matters. And here I'd like to explain some of the surgical workflow for the open heart surgery. And we have an anesthesiologist, perfusionist, and surgeon here. And after the induction of anesthesia, we will work on the femoral catheterization and cervical major vessel. We will isolate them. After thoracotomy, we need a heparinization because we will do bypass. During the bypass, the blood will go through the tube. That will promote the clot. That's why we need a big amount of heparin through this procedure. And after initiating, after cannulation to the big vessels, we can start cardiopulmonary bypass. And we need stretch the pericardium to visualize the heart. And then we can approach to the aorta, and we will cannulate small cannula. And then we can, after we clamp the aorta distal to the cannula, and we can perfuse the cardiac pressure. That includes the high potassium solution. And that can stop the heart immediately. And after that, we can cut the left atrium without any moving of the heart, and the blood will only stay. So we can get a really good visualization in the heart. And the first, we will do mitral valve orientation, look at the cord, is it ruptured or not, and how many cords we need to repair the disease. And the key procedure is these 2 yellow colored procedure. One is neocord implantation, and the next is suture angioplasty. I will explain just a little bit about our procedure in the next slide. And after that, we will do the saline test to make sure it's closed well. And as Dr. Uechi mentioned about the difficulty getting a perfect repair, because even if we see a best result in this test, the leakage can still happen after we repeat the heart because the position of structure slightly change when it actually beats. And after we kind of make sure the regurg is well controlled, we will close the left atrium with a continuous manner, and then we will perfuse hot blood to the coronary circulation, then we can get repeat. And sometimes we need a defibrillation at this point. And if the heart is beating well, we can decannulate the aortic cannulation cannula, and then if the patient was stable, we can wean off the cardiopulmonary bypass. And if we finish using cardiopulmonary bypass, we will antagonize heparin by protamine, and then after that, we can get a good coagulation typically. And then we can close the chest after making sure there's no big hemorrhage inside the chest. And then finally close the rest of the wound and then finish the suture. And you can see the bypass circuit here. The venous blood is come from the jugular and then going to the reservoir and going to the main pump and the artificial lung. And then the blood is oxygenated and then going to the carotid artery and the whole body except for the heart. And our team has sat pump here and hemoconcentrator to concentrate, sometimes remove the waste, like cytokines or PU and creatinine. So this is this is the slide what we are doing during the open heart. And you can see the normal heart here. This is a mitral valve structure. The leaflet, 1 is a leaflet, 2 is a chorda tympani, and 3 is a papillary muscle. And this is a diseased heart before repair. And you can see the ruptured cord. Sometimes it's just elongated, but this here, you can see the ruptured cord. But basically, the first thing we do is place the new suture, like we place at least 8, and we sometimes place 10 to 15 as needed. So after the height of the leaflet is the same as the level of aneurysm, and then we will move forward to go to the suture angioplasty. We can see the heart, the aneurysm of mitral valve is pretty dilated. Mostly we see this situation for diseased dog. So even if we treat the height of the, adjust the height, there still be the gap between 2 leaflets. So we need to make sure these leaflets will match, coapt each other after the suture angioplasty. And this is one of our papers showing the procedure. And here we use the loop technique, loop-in-loop technique. And here we place 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 nail cores. And here you can see the angioplasty. We typically start from the right fibrous triangle and go this way, and then go from here next, and then they will meet each other here. So this slide, I'm going to show you some of the actual movie when I doing this procedure. So you can see the anterior leaflet here, and then this white structure is project, and the surgeon is now placing the cores to the loop. And once it passes through the loop, the surgeon will grab the anterior leaflet and pass the needle through the tip of the leaflet twice. This is a double surgery. And then after that, adjust the height of the leaflet to the level of mitral diameter and grab the suture to make sure it's not moving when tying and tying. The speed is multiplied, so you don't have to do it. So sometimes the surrounding tissue get dry, so you have to make sure it's good. And again, the other suture will go to another part of the mitral leaflet. So this is the anterior. Sorry about that. So this is the posterior conch side. This is still A2. Adjusting the height, and then so the disadvantage of this procedure is this is pretty subjective way to adjust the height, but the advantage is this can apply to any condition, any weird position of the papillary muscle, dogs has different shape of the leaflet all the time. Next. So from here, I'd like to share our experience when we launched the open heart surgery program in the University of Florida. We just started 2 years ago. In the beginning, our team from Japan, I bring all the members, perfusionists, anesthesia, and assistant, even a technician. I brought them, and then we did 3 surgery. And after that, most of the staff go back to Japan, and I and just one assistant surgeon stay in the US for 2 months, and after 2 months, just only me was in the whole team of the IUF. And we were lucky to have these perfusionists around Gainesville. They're really skillful, and they're pretty cooperative. They are human pediatric perfusionists. They're so skilled, and they understand some about what happens when we do bypass for dogs in these 3 cases. And after that, the US perfusionist did all the perfusions. And then we started a surgery fellow program, and this is Dr. Chu. She's a surgeon, and she's now doing about 70 to 80% of the procedure. We are still doing. I'm still doing surgery with her, but hopefully. So this is a 2-year fellow program. So hopefully I expect she can do surgery individually until next July. And the change we made is we hired Japanese perfusionists because we'd like to increase the caseload, and at the same time we'd like to start the program by increasing the number of surgeons and also perfusionists in the US. And we have in-house perfusionist. He is a Japanese perfusionist. He has over 1,000 cases experience doing open heart surgery for dogs. And we luckily have a new fellow for the perfusion program. So again, this is our goal to expand this surgery in the US. So as you can imagine, to perform this surgery in a big hospital like University of Florida, we need to make sure we are not overwhelming other service, and also we need to commit to the patient safety, and we need to talk each other. This is a new surgery for everyone, and so anesthesia, cardiology, perfusion, and surgery operation room and intensive care unit, and we are having good communication, and I will show you the result of this collaborative work. We are getting very promising results so far. So I'd like to share just an example of how we facilitate the conversation. This is the format of a structured meeting after surgery. So now we are doing surgery on Thursday and Tuesday, and we have a debrief meeting on Wednesday morning. And so each service will raise the point we get in the previous surgery, and we can discuss about how it worked, how it didn't work. And then we can, in this way, we can facilitate, improve the way to manage the issue if happen during surgery. For example, it's there, but sometimes we see a pressure drop, sudden pressure drop during the infusion requirement. And then we need some pressure during that time immediately. And we need to make sure the communication is going well, and the dose should be administered correctly and fast. And sometimes the fingerprinting works, sometimes NORAP works, sometimes the building works, and then we will discuss how it worked, how we managed successfully. So far, we didn't lose any case for this reaction. And the other example is from the perfusionist. We sometimes has comments and discussion on when to unclamp the aorta during rebeat process. We need to wait until the heart is getting warm and getting beat well, unless the backflow from the aorta will damage, expand the left ventricle, that can damage the myocardium. And surgery usually, it's usually uneventful. Sometimes we need a defibrillation. We are making sure the process of the defibrillation well, and have some discussion with anesthesia and perfusion, how to improve, how to prevent fibrillation. And ICU staff is also joining this meeting, and treatment option for hypotension, arrhythmia after surgery, and we can talk about surgeon can provide some suggestion, and also anesthesia can talk about that, like a reaction to the pressor. How was the reaction during the anesthesia? And we also talk about the next week's case at this point, and then sometimes we have an aortic regurgitation, dogs, and pulmonary hypertension, chronic kidney disease, and we can talk about how we minimize the risk and complications beforehand, and that way we can arrange the treatment the day before. And this is a case screening process. So I have only 5 minutes, so I'll go really quick. So here, so most of our patient is coming from outside Florida, sometimes Canada, sometimes South America. So we have submission portal through online website, and we have an in-hospital team discussion, and after that we have online meeting with clients. And then if owner is aware of the risk and complications and what will happen during and after surgery, and then we can schedule surgery. And the pre-op evaluation usually completed by the local vet. And then we will intake the patient the day before. In this flow, we only have one case. We had to postpone surgery because of the pneumonia happened right before. So far, this flow is working really well, even if they are coming from far. And this slide showing the current where we are. So until this September, we did 1 case per week, and we now we are doing 2 cases per week. We did 2 weeks for 2 cases per week, and all dogs doing fine. And this is kind of important information you may be interested in. And the first half, 38 cases. So far we have 76 cases done, and we had 87% survived to discharge at the first half. And the second half this year we had a better result. We are getting well-organized system, well-controlled treatment against even the patient condition was serious. And this is important slide for me because my goal is to expand the program in the US. So as I said before, the fellow, the current fellow, Dr. Chu, is now doing some of the aortic procedure. This is the most high-risk procedure during surgery, and she done all these procedure with me, and then now after she get this skill, then she can do the surgery by herself. And also Parvision Fellow program is going well. The current fellow will end next July, so we are actively hiring new fellow for the next year. If anyone interested in, please reach out to me. And then this is some information about fellow training for perfusion. We think ECC, board certified doctor, veterinarian, and or cardiologist will be qualified this program. This is a final slide. Open heart mitral valve repair have been implemented in the University of Florida, and multidisciplinary collaboration is the key to get reasonable success. And next goal is increase the case volume and expand training and education for this procedure, and reporting long-term follow-up outcomes is also important. So we do that. Thank you for joining this session. I think I talked a little bit a lot, so it's 2 p.m. So I'll pass this on to Dr. Kwon.